Okay, so it's like pathological murmur as because there is 2 by 6 hollow systolic murmur. Always hollow systolic and diastolic murmur is pathologic, but mid systolic or early or mid systolic murmur is physiologic. So in pathologic murmur you need to do ECG and echo, and for physiologic murmur you need to reassure the patient. Got it? Next. Okay, it's look like athlete's heart. If we look at the table first, in hypertrophic HOCM like HOCM, family history is common. In athlete's heart, usually unremarkable. ECG finding in hypertrophic cardiomyopathy, left ventricular criteria with depolarization and repolarization abnormalities. LVH criteria with depolarization and repolarization abnormalities. In athletes' heart, left ventricular criteria without other abnormalities. The most catching point in here, like left atrial size. In hypertrophic cardiomyopathy, left atrial size will be enlarged, but in athlete's heart, left atrial size is normal. Left ventricular size usually decreased in HOCM, but slightly increased in athlete's heart. Left ventricular wall thickness is more in HOCM, but less than 15 in athlete's heart. Focal septal hypertrophy is more in hypertrophic cardiomyopathy, but no focal septal hypertrophy in athlete's heart. And left ventricular function is impaired in HOCM, but normal in athlete's heart. Okay, differentiation of the physiologic changes of the athlete's heart. Can you hear me? Yeah. Okay. Differentiation of the physiologic changes of the athlete's heart from serious underlying pathology that increase the sudden cardiac death. HOCM is highly important. These young athlete who has undergone intensive endurance training has the characteristics of athlete's heart. Those include the following: eccentric left ventricular hypertrophy with enlarged eccentric left ventricular hypertrophy with enlarged left ventricular cavity size and slightly increased left ventricular wall thickness, enlarged left ventricular cavity size, increased stroke volume with unchanged left ventricular ejection fraction, absence of left atrial enlargement, sinus bradycardia at rest, often with low-grade AV block, first degree or Mobius type 1, resulting from increased resting vagal tone. Additional ECG findings that can be seen include increased QRS voltage and J point elevation, isolated T wave inversion in V1 is relatively common in general population, including the athletes. In contrast, characteristic echocardiographic findings of HOCM include asymmetric left ventricular thickening that favors the interventricular septum with resultant reduced left ventricular cavity size and left atrial enlargement. ECG often demonstrates abnormality in the depolarization, that is, a prominent Q waves and repolarization T wave inversion in two contiguous legs. Got it? Okay. It's AS, ankylosing spondylitis. This patient with chronic chronic back pain and intermittent bilateral heel pain, chronic back pain, intermittent bilateral heel pain, enthesitis as impaired. Okay, sorry. This patient with chronic back pain and intermittent bilateral heel pain, intermittent bilateral heel pain, enthesitis as well as impaired spinal mobility, limited chest expansion, most likely has AS, a rheumatological disease primarily involving the inflammatory arthritis of the spine. Limited chest expansion does not fully explain his exertional shortness of breath, and significantly reducing exercise capacity and does not account for a lately displaced point of maximum impulse. Therefore, this patient is likely developing chronic heart failure due to chronic heart failure due to chronic AR, a potential complication of the AS. AR occurs up to 10% of the patients with ankylosing spondylitis. It likely results from chronic inflammation of the aortic root and valve cusp, resulting in retraction of the valve cusp and consequent impaired valve closure. Over time, aortic regurgitation causes left ventricular volume overload with compensatory eccentric hypertrophy, and lateral displacement of the point of maximum impulse. Rarely, the chronic inflammation can extend into the interventricular septum and cause conduction abnormality. Advanced AV block as well. Okay, the box like uh, eccentric left ventricular enlargement and heart failure. If there is left ventricular dysfunction, it may be due to ischemia or cardiomyopathy. It will decrease the left ventricle. It will causes left ventricular volume overload. And if there is valvular dysfunction like AR, MR, it will also cause left ventricle volume overload. If there is left ventricular volume overload, left ventricle will stretch, increase stroke volume via Frank-Starling law, initially maintains cardiac output, but chronic volume overload, it will cause eccentric hypertrophy. It will increase the stroke volume is maintained, increased stroke volume is maintained at expense of increased wall stress. It preserves cardiac output, and overwhelming wall stress and left ventricle enlargement and contractile dysfunction, decompensated heart failure. So asymptomatic and symptomatic will cause decompensated heart failure. Okay, got it. Okay, I thought ASD is usually in the pulmonary area. That's why I got wrong. I thought, isn't it? Oh, I predict wrong. I was sure that it would be ASD, or I was a bit confused with C and D. I I just missed because yes. So 2 by 6 mid-systolic murmur at the left upper sternal border. Left upper, which is the pulmonary area. That's it. So atrial septal defect is a congenital heart defect that usually remains asymptomatic until adulthood. Pregnancy which increases Pregnancy which increases the circulating blood volume often precipitates the first clinical manifestation of the ASD. These relatively high pressure, the relatively high pressure of the left atrium compared to the right creates and left to right atrial shunting that leads to right-sided volume overload. Consequent atrial stretching may trigger atrial arrhythmias, paroxysmal atrial fibrillation, often described by patients as palpitation or periods of heart rate. Patients may also experience decreased exercise tolerance, fatigue, dyspnea, pulmonary hypertension, and right-sided heart failure can develop, and if left untreated can really progress to Eisenmenger syndrome. Okay, uh, look at the Eisenmenger syndrome. It is left to right shunt through ASD, VSD, or PDA. Over time, pulmonary vascular resistance increases, leading to bidirectional flow. Ultimately, there is right to left shunt. Continued increase in the pulmonary vascular resistance lead to shunt reversal. Eisenmenger. Okay. Yes. Yes. Cardiac auscultation in patients with ASD. Cardiac auscultation in patients with ASD typically reveal wide and fixed splitting of S2. In addition, flow murmurs caused by increased blood flow crossing the pulmonary valve, that is, mid-systolic murmur at the left upper sternal border, and tricuspid valve mid-diastolic rumble may be present. In patients with large left to right atrial shunting, echocardiography shows right atrial and right ventricular dilatation. The ventricular dilatation may slow right-sided conduction and cause a right bundle branch block on ECG. Choice A. Anomalous coronary artery. Anomalous coronary artery is relatively rare congenital heart defect with numerous variations involving an abnormal origination point of one of the coronary arteries. Patients can be asymptomatic or present with exertional angina, syncope, sudden cardiac death. Right ventricular dilatation is not expected. Next. Okay, this patient with blunt this patient with evidence of blunt chest trauma, sternal bruising following rapid deceleration more than 3 meter, like 10 feet onto the pavement, is at risk for blunt thoracic aortic injury. Rapid deceleration exerts stretching, shearing, and torsional forces capable of rupturing the aorta. Aortic stimulus, the transition zone between relatively mobile ascending aorta or arch and the fixed descending aorta, is particularly vulnerable to these forces and the most common site of blunt thoracic aortic injury. Complete aortic rupture, tear in the intima, media, and adventitia typically results in rapid exsanguination and death. This patient who survived the fall likely has an incomplete rupture, tear of the intima with or without media, which results in creation of a secondary false lumen similar to aortic dissection, creation of secondary false lumen similar to aortic dissection, creation of an obstructive intimal flap or intramural hematoma that impedes distal blood flow, pseudocoarctation resulting in proximal hypertension and distal hypertension, upper extremity hypertension with diminished femoral pulse, and expansion of the adventitia under high flow pressure causing compression or stretching of the surrounding structure such as the left recurrent laryngeal nerve, hoarse voice. CT angiography of the chest is highly sensitive. CT angiography of the chest is highly sensitive and specific for thoracic aortic injury and is readily available. Transesophageal echocardiography can also be Transesophageal echocardiography can also evaluate the thoracic aorta but requires an experienced echocardiographer. Transthoracic echocardiography does not adequately visualize the thoracic aorta, progressively becomes a more posterior anatomical structure closer to the esophagus as it arches and transitions into the descending aorta. Incomplete rupture should prompt emergent surgical evaluation. Yes, esophagography, water soluble contrast, evaluates esophageal perforation. Although esophageal rupture can occur with blunt chest trauma and cause severe chest and back pain, it does not cause differential blood flow between the upper and the lower extremity. And D. Flexible bronchoscopy visualizes the proximal airway lumen and can diagnose tracheobronchial injury, who classically causes pneumothorax and pneumomediastinum, severe respiratory distress, diminished breath sound, and/or crepitus subcutaneous emphysema. Yes. Okay. First box, extremity vascular trauma. Extremity vascular trauma, there are some hard signs, there are some soft signs. Hard sign is observed pulsatile bleeding, presence of bruit or thrill, expanding hematoma, and signs of distal ischemia distal ischemia. And soft signs are history of hemorrhage, diminished pulses, bony injury, neurological abnormality. Evaluation: if heart signs or hemodynamic instability is present, surgical exploration. If otherwise, injured extremity index, CT scan or conventional angiography, duplex Doppler ultrasonography. Okay, so this patient with penetrating injury to the anteromedial portion of the upper thigh and hard evidence of vascular injury. Hard evidence of vascular injury should undergo prompt surgical exploration. This initial evaluation and management of the patient. This initial evaluation and management of the patient with severe extremity injury includes hemorrhage control, radiography, radiography of the skeletal injury, and evaluation of the neurovascular bundle Vascular assessment should focus on identifying the hard signs of the injury, including observed pulsatile bleeding, presence of bruit or thrill over the injury, expanding hematoma, and signs of distal ischemia. So absent pulse or cool extremity. In the presence of penetrating injury, such signs with or without hemodynamic instability are most likely universally predictive of the need for urgent surgical repair and warrant immediate exploration. If the area of damage is unclear, arteriography can be performed intraoperatively to clarify anatomy. If hard signs are absent, further evaluation for soft signs, history of hemorrhage, diminished pulses, bony injury, neurological abnormality should occur. If present, these signs indicate the need for additional testing such as the injured extremity index, similar to ankle brachial index, which involves comparing the systolic pressure distally in an injured extremity to the occlusion pressure at the site of proximal site in an uninjured extremity. If the index is abnormal, less than 0.09, patient should be considered for CT scan or conventional arteriography and surgery in conjunction with the management of other injuries like bony damage. Got it? Okay, this is myocardial perfusion scan. Uh, so in supine position, look, the heart is well perfused, but in the stress condition, when you are stretching the heart, there is a decreased perfusion, like the red color is diminishing. Make differentiate from down to upwards. Yes, yes. Okay. So radionucleotide myocardial perfusion imaging, nuclear stress testing makes use of technetium techneted 99 radio labeled tracer system maybe to evaluate myocardial perfusion and test for obstructive coronary artery disease. The tracer is injected with the patient at rest and the initial images are obtained. The patient is then subjected to stress via treadmill exercise or pharmacological inducement, and images are obtained. Top panel, any difference between the rest and the stress. Any difference between rest and the stress images can help identify ischemia. Normal tracer uptake at rest. Normal tracer uptake at rest and with stress indicates low likelihood of obstructive coronary artery disease. Normal tracer uptake at rest but decreased uptake with stress, reversible defect indicates and and likely hemodynamically significant atherosclerotic narrowing that restricts exertional blood flow and decreased tracer uptake at rest with stress fixed defect indicates likely scar tissue consistent with obstructive coronary artery disease with previous myocardial infarction. These patients finding indicate reversible defect, that is a diagnostic of coronary artery disease. Patient with known coronary artery disease should be treated with antiplatelet therapy, aspirin, high intensity statin, atorvastatin, rosuvastatin to reduce the risk of myocardial infarction. In addition, lifestyle modifications, smoking, routine exercise, healthy diet should be implemented to reduce the cardiovascular risk. Got it? It will not gonna perfuse. And if there is decreased uptake, like somebody has MI and there is scar tissue, so when you there is decreased tracer uptake at rest with stress indicates scar tissue. That means he has a previous MI. Okay, so this patient has hypertriglyceridemia, which can occur due to an inherited disorder, familial hypertriglyceridemia, acquired condition, diabetes mellitus, heavy alcohol consumption, heavy alcohol consumption, or as an evidence of medication beta block or corticosteroid. Elevated triglyceride levels more than 150 are associated with increased risk of cardiovascular risk, and severely elevated more than 1000 can cause pancreatitis. In patients with hypertriglyceridemia, if more than 150 to 500 who have known are at high risk of atherosclerotic cardiovascular disease, statin are the recommended first line pharmacotherapy. Mm, Recommended first line pharmacotherapy. Increased exercise and weight loss are beneficial. In addition, heavy alcohol intake can significantly increase TG level. Therefore, these patients should reduce alcohol intake to not more than 2 drinks per day, or 1 drink for women. Got it? Yes. Okay. Fibrates. Option C, fibrates. Gemfibrozil and fenofibrate are the most effective pharmacological therapy for reducing triglyceride level and are recommended in patients with moderate to severe hypertriglyceridemia more than 500 mg per dl. However, due to cardiovascular benefit, statins are recommended first line in patients with ASCVD and mild hypertriglyceridemia. Because of increased rate of adverse effect, myopathy, and the lack of proven cardiovascular benefit, the addition of fibrate to a statin is rarely indicated. Okay, if you look at the box, if the TG level is 150 to 499, like 150 to 500, just limit alcohol intake. You can use gamma 3, uh, omega 3 fatty acids, omega 3 fatty acids, if risk of ASCVD. If um, TG level is 500 to 999, abstain from alcohol, omega 3 fatty acid, or fibrate can be used. But if TG level is more than 1000, you should use fibrate to reduce, like fenofibrate or gemfibrozil. These drugs should be given, must be given if TG level is more than 1000, because it can cause pancreatitis. Yes, yes, all of them we can give statin. Statin is the statin is the primary drug for hyperlipidemia or hypertriglyceridemia because it has like mortality benefit, but fibrate has not proven any mortality benefit. It is given to decrease the risk of pancreatitis, and it is not given combinedly because it can cause myopathy or rhabdomyolysis. If fibrates and atorvastatin given simultaneously, it can cause myopathy or rhabdomyolysis. Got it? Okay. This patient's clinical presentation: abrupt onset regular tachycardia, abrupt onset regular tachycardia that resolves, abrupt onset regular tachycardia, abrupt onset regular tachycardia that resolves with cold water. Sorry. Uh, this patient's clinical presentation: abrupt onset regular tachycardia that involves cold water immersion, is consistent with paroxysmal supraventricular tachycardia. AVNRT is the most common cause of paroxysmal supraventricular tachycardia and frequently develops in young patients with a structurally normal heart. Young patients with a structurally normal heart. Palpitation are common presentation, but some patients may have dizziness, shortness of breath, or chest pain. AVNRT is due to presence of two conduction pathways we know, fast and slow, in the AV node. Normally, sinus beats are conducted in anterogate direction through the first pathway, and as the anterogate conduction through the slow pathway is extinguished due to the presence of a refractory period. If the atrial premature beat occurs at a critical time when the first pathway is refractory but the slow pathway is not, it can initiate AVNRT that is then sustained by re-entry mechanism. That is the sustained by re-entry mechanism. The slow and the fast form a loop circuit with impulses traveling into the anterogate direction through the slow pathway and returning through the first pathway. So vagal maneuver, carotid sinus massage, cold water immersion, or diving reflex, Valsalva maneuver, eye wall pressure increases parasympathetic tone. See, these vagal maneuver increases parasympathetic tone in the heart, resulting temporary slowing of the conduction in the AV node and decrease in the AV uh, refractory period, leading to termination of the AVNRT. Okay. Okay, this patient with a history of this patient with a history of breast cancer has this patient with a history of breast cancer has developed a large malignant pericardial effusion, with associated dyspnea, chest discomfort, and tachycardia. Malignancy is a common cause of pericardial effusion, which may be initial clinical manifestation of the recurrence, as in this patient. Common tumor types with malignant pericardial effusion include breast cancer, lung cancer, and the lymphoma. Subacute accumulation of the pericardial fluid. Subacute accumulation of the pericardial fluid over weeks gives the pericardium time to progressively stretch, and therefore a large volume 700 ml may accumulate. Patients often experience only non-specific symptoms, dyspnea, chest discomfort, until enough fluid, typically 1 to 2 liter, accumulates to increase intrapericardial pressure and compromise cardiac function, cardiac tamponade. Management of malignant pleural effusion consists of the following: acute drainage. Pericardiocentesis is performed to relieve patient symptoms and treat early signs of cardiac compromise, tachycardia, and or obtain fluid for cytologic evaluation and prevention of reaccumulation. A mean of a prolonged pericardial drainage is recommended because fluid reaccumulates frequently, up to 60% of the cases. This is typically achieved either through the creation of the pericardial window or through a prolonged pericardial catheter drainage. Got it? Yes.
Okay.
Do you think I fall asleep? No, it's my problem. I sometimes fall asleep while talking to you. I have I have I figure it out. I don't know, but I have some sort of narcolepsy. Yes. I just diagnosed myself. It is not diagnosed. Okay. So this young patient has new onset hypertension in combination with epistaxis tremor, borderline tachycardia. Epistaxis tremor, borderline tachycardia suggests secondary hypertension due to cocaine intoxication. Secondary hypertension due to cocaine intoxication. Cocaine is a potent stimulant that causes a sensation of euphoria and increased alertness. However, the symptomatic effects of cocaine cause hypertension and tachycardia in a dose-dependent fashion. Other illicit drugs associated with hypertension include other stimulants, amphetamine 3, MDMA or ecstasy, phencyclidine, marijuana. Cocaine is also a prominent cause of epistaxis when administered intranasally, although epistaxis is sometimes attributed to uncontrolled hypertension of any cause, and the pathophysiologic link is not strong. Although most patients with elevated blood pressure have primary hypertension. Further diagnostic evaluation is indicated for patients with signs and symptoms of disease associated with secondary hypertension. Suggestive features include an early onset. Suggestive feature include an early age of onset, age less than 30, in the absence of family history, severe or malignant hypertension, resistant hypertension, despite an appropriate 3-drug treatment regimen, and a sudden rise in the blood pressure in a patient with previously well-controlled hypertension. In light of patient's clinical presentation, a urine drug screen a urine drug screen should be obtained to evaluate for illicit drug use. Okay. Okay, so this patient's presentation: recent cardiac catheterization, anticoagulation with heparin, sudden onset hypotension, diarrhea, flattening veins, and back pain, is consistent with retroperitoneal hematoma due to bleeding from arterial site with retroperitoneal extension, local vascular complication at the catheter insertion site, bleeding, hematoma localized or with retroperitoneal extension, arterial dissection, acute thrombus, pseudoaneurysm, or AV fistula formation are the most common complication of cardiac catheterization. Most hemorrhage or hematoma formation occurs within 12 hours of catheterization. Patients with hematoma present with localized discomfort and or swelling of the soft tissue. If the arterial puncture site is above the inguinal ligament, the hematoma can extend into the retroperitoneal. The hematoma can extend into the retroperitoneal space even with minimal visible localized hematoma and present with sudden hemodynamic instability and ipsilateral flank or back pain. Diagnosis is confirmed with CT scan of the abdomen and pelvis and abdominal ultrasound. Treatment is usually supported with intensive monitoring, bed rest and IV fluid or blood transfusion. Surgical repair of the hematomas and retroperitoneal hemorrhage is rarely required. Since local hematoma formation is not uncommon, patients should be advised to avoid strenuous activity or lifting heavy objects for 1 week post catheterization. Radial artery approach leads to fewer local vascular complications, which has led to an increasing number of cardiac catheterization being performed via this approach. Okay, okay. It's right heart failure. So, uh, right ventricular myocardial infarction, right heart failure. In right heart failure, look at the picture. The right atrial pressure or central venous pressure will be increased, but pulmonary capillary wedge pressure is decreased, cardiac output is decreased, and systemic vascular resistance is increased. So these patients severe. So these patients severe. These patients severe pressure like chest pain, and ST elevation. ST segment elevation in ECG leads 2-3 AVF are diagnostic for inferior wall myocardial infarction, which commonly involves the right ventricle. ST segment elevation in the right precordial ECG VRR4 confirms the right ventricular myocardial wall infarction. Bradycardia in the setting of hypotension is another clue of right ventricular myocardial wall infarction because right ventricular myocardial infarction frequently involves ischemic disruption of the SA and AV node. Right ventricular ischemia causes an abrupt decrease in the right ventricular contractility, leading to increased right ventricular end-diastolic volume. Preload and increased pressure is transmitted backward to increase right atrial and central venous pressure and causes jugular venous distension. With impaired right ventricular contractility, decreased blood is pumped through the pulmonary circulation to the left atrium, resulting in low pulmonary capillary wedge pressure, an estimate of left atrial pressure, and decreased left ventricular preload. Pulmonary edema is absent and the lungs pulmonary edema is absent and the lungs are clear to auscultation. With reduced left ventricular filling, cardiac output drops to hypotension and there is compensatory vasoconstriction to increase the systemic vascular resistance and help maintain blood pressure. Okay, this patient with the recent cardiac surgery developed tachycardia, tachypnea, distant heart sound, enlargement of the cardiac shadow on chest X-ray suggestive of pericardial effusion. A pericardial effusion occurs when inflamed pericardial cells produce increased fluid which accumulates in the pericardial sac around the heart. This is common in few weeks after cardiac surgery due to immune mediated inflammatory damage to the pericardium post cardiotomy syndrome. Small pericardial effusion are usually asymptomatic because the pericardium stretches to accommodate the fluid. However, large effusion can compress the heart and can impair cardiac filling. Infants can develop decreased appetite, vomiting, whereas older children may present with pericardial friction rub, pleuritic chest pain, fever may be present due to inflammation, tachypnea, tachycardia occur in response to decreased cardiac output. The effusion obscure auscultation causing distant muffled heart sound on examination. Fluid accumulation Fluid accumulation around the heart causes enlarged cardiac shadow on chest X-ray as seen in this patient. Postophrenic angles remain sharp unless there is accompanying pleural effusion. The stomach bubble is a normal finding that can be seen. Echocardiogram confirms the diagnosis. Patient with signs of hemodynamic compromise should undergo drainage of the pericardial fluid. Okay. Okay. So this patient's chest pain characteristics boards with deep inspiration and relief with leaning forward, and ECG finding diffuse ST segment elevation with reciprocal ST depression in V1 and AVR, reciprocal ST depression and V1 and AVR. Looks like pericarditis. Given recent MI, a most likely post-cardiac injury syndrome, a pericarditis that can occur weeks to months after cardiac injury. When pericarditis occurs following MI, when post-cardiac injury syndrome occurs following MI specifically, it is it may be referred as Dressler syndrome. It may be referred as Dressler syndrome. Post-cardiac injury syndrome represents an immunologic response to damaged mesothelial pericardial cells and blood in the pericardial space. In addition to the chest pain, patients often have malaise, sometimes fever. Inflammatory markers include ESR, CRP are typically ESR, CRP are typically elevated. Appropriate therapy consists of NSAIDs in the form of high-dose aspirin, 975 milligram 3 times daily, or non-aspirin ibuprofen 800 milligram 3 times daily. Aspirin is usually preferred. Aspirin is usually preferred because post MI are usually taken in low dose for the antiplatelet effect. Colchicine may be added for enhanced anti-inflammatory effect. Corticosteroid can be used for refractory pain when NSAID are contraindicated, but they are less effective overall. In post-cardiac injury syndrome, infarction pericarditis results from local myopericardial inflammation, usually develops within 4 days of MI. Treatment with NSAID is usually avoided due to possible increased risk of myocardial rupture in the early post-MI period. In early post-MI period, we actually avoid NSAID, but in here the MI happens long ago, so several weeks or months ago, so we can use NSAID in here like ibuprofen 800 milligram 3 times a day. Got it? Sorry. Early post-MI low dose aspirin is enough. We do not need this high dose aspirin. Okay, can we take a break? Okay.